One thing that happened over the weekend, of all things, Senate Democrats passed their $740 billion tax climate healthcare package after an all-nighter. They wanted initially $3.5 trillion, so they didn't get all that, thank God. But this package now moves to the House, and they could vote this, I want to say on Friday, as early as Friday, to get it to President Biden to be signed into law. But there's a couple elements here, too, and the question would be, is this really going to lower drug prices, healthcare prices, and all that, as it was intended to do, because it is inflation relief after all. At least on that one element, because I said there's other things in here, too, including climate change and other stuff, taxes, too, as well. But we'll focus on the healthcare part of this with Paul Seegert from PCS Healthcare Advisors. They advise businesses of all sizes, shapes, and forms on how to reduce their medical costs. Paul, good morning. Welcome back. Good to have you.
Thank you. Glad to be here.
Yeah. So this thing, I'm just running down the list of what it does. The federal health secretary can negotiate prices of expensive drugs, certain drugs for Medicare. There's a 3-year extension on healthcare subsidies in the ACA. And then we get into the tax elements of this, and 15% minimum tax on corporations that make $1 billion or more tax enforcement for the IRS, a 1% excise tax on stock buybacks. That's how they're going to pay for this whole thing. But let's talk about your field of expertise in your wheelhouse, and that is if this is actually going to reduce prescription drug prices. I'm going to guess it's probably going to reduce them and do well for Medicare recipients, but for those of us who get private health insurance, not so much.
Yeah, in the short run, it'll reduce costs for Medicare recipients. I think in the long run, it has the potential to increase healthcare costs overall. I'm happy to explain that. And it's really not negotiation. If you said, hey, if somebody that makes a product said, I want $10,000 for this product, and you said, I'll give you $1,000, and if you say no, I'll tax 95% or give you a penalty that's equivalent to 95% of the sales of your product, that doesn't sound like a very easy negotiation.
No.
And that's pretty much the simple way of the land here. Either do it or, it's a gun to the head negotiation. So
yeah, you don't have a choice.
It's price controls. And the challenge, there's lots of challenges with it. And it's funny to be having this conversation because I'm usually on these interviews talking about big pharma, saying that the whole R&D excuse for any legislation that impacts their revenue is a red herring, and it usually is. But in this case, it isn't. They've created a real disincentive for big pharma to continue to create blockbuster drugs, and not just blockbuster in revenue, but life-saving drugs, because they're going to have a very difficult time quantifying their ROI. And it even creates part of this rule or law will give them 9 years of exclusivity on a drug before it can be added to the price control list. The problem is once you get an approval on some of these drugs, these drugs often have a really long lifespan or history of R&D or studies, rather. So you get a drug approved, and then you start to do additional trials to figure out, okay, will it work in this population? Will it work for this disease? Because some cancers are related and they're caused by the same things. And so this creates a disincentive for you as a drug company to do some of those additional trials to find additional ways that it can be used. Because if it becomes too successful, it's going to get pushed over to the price control list, and it's going to, totally gut your revenue.
Interesting.
But that's a major problem with this bill.
Wow. I never considered that too. Because in all fairness, you've come on many times when we've talked about the evils of big pharma and pharmacy benefit managers. So you call it like you see it, which is why I love having you on, Paul Seegert. But in this case, you're saying that's not overblown, that this is going to stifle innovation because, well, look at it this way. If you have to provide drugs for a loss to the Medicare segment of consumers, you're going to make up for that by hiking the price of things, those in private care. So if you get your health insurance on the free market or through through your employer, for example, which most of us do, something like 220 million privately insured Americans like me, and maybe if you're listening to this thing, the inevitable result will be that your prices are going to go up to offset the losses for Medicare.
Exactly, and we already know that to be the case. You can simply look at the way the hospital business in our country operates and see what's happening and it can kind of tell the future for us, or at least give us some clues. If you go to a hospital today and you have government provided care, that hospital loses money on that transaction. They typically need 120, maybe as much as 140% of what they got from you or from your health plan, rather, Medicaid, Medicare, to break even. And then then everyone else that walks in to that hospital has to get charged more because they represent the profit opportunity for that hospital.
Right.
And that's not right, wrong, or indifferent. That's what the government saying this is what we're willing to pay has created in terms of a dynamic in the overall industry. So when you go into a sector of payers, or you section off a percentage of payers, how does that impact the rest of the payers? I mean, that is a serious problem because you're simply squeezing a balloon.
Yeah.
When we look at Big Pharma's overall revenue, maybe they chip away a few points. I mean, they're looking to take $250 billion over time away from Big Pharma and essentially move it towards other things that they prioritize, green energy and so on. But are they really going to take it away, or are they just going to push it around? And I think what's going to happen is like what's happened in hospitals. You have a payer that's going in as a private payer. Their plan pays 3.5, maybe even as much as 12 times what the Medicare payer paid for the same procedure to make up the difference.
Right. And so drug makers got to give discounts to Medicare patients on drugs, for example. They compensate by raising prices elsewhere. I get that. And I don't understand how that's supposed to reduce inflation because now I get less take-home pay because my employer costs are going to be passed on to me in order to offset to an offset Medicare. So, and the problem, I guess, too, is how much money do companies lose and healthcare providers lose because of Medicare? They don't, as I understand it, the cost of Medicare procedures or medicine, whatever, is less than what they're going to reap in profit, right? So they're giving the Medicare as a loss being forced by the government. Is that true?
That is true in many cases, and that's the very reason why. When you have people that stand up and say, hey, we ran the numbers, it would be cheaper for us to have Medicare for all. It's laughable because the quality that you experience today, that would not be possible because you're getting subsidized. It's the opposite of how people think. The government isn't subsidizing the system. The government is getting subsidized by private payers in our system. And we're at risk of doing the same thing with drugs. And it's really funny to watch in a sick kind of funny way because we could clean this whole thing up back to the conversations we've had in the past with the waste that's attached to the cost of drugs. We don't have to go after the manufacturers to clean it up. They're not responsible for the waste attached to the cost of drugs. You got 30, 40, 50, 60% of the cost being added by middle players that don't add real significant value. At least they don't make drugs, wholesale drugs or retail drugs. And if we could simply pass some common sense guideposts to work within that removed some of this waste, we could lower costs for everyone in the whole system. It's obviously silly that we have consumers in this country in many cases paying 10x for the same drug out of the same factory as our counterparts in other countries. And it's not the manufacturers that are doing that. It's these other players.
Well, the other players are, of course, well, then if we did that, though, and just made, hey, this is what the cost of the drug is, like you'd go to buy soup, for example, then you wouldn't need Nancy Pelosi and Schumer and all these guys trying to get money. I mean, let's call it what it is, right? It's if drug makers raise here's what they're going to do. They're going to raise their prices to the private sector to take the Medicare hit. And then what'll happen is when that goes up, Democrats are going to have a new reason to go after the industry again down the line. It's a self-fulfilling prophecy. It's in a way, and I always go back to this thing, the college scam that's been exposed is now it's always been played out in other industries, right? It's like, well, we need more subsidy. Okay, we'll give you more subsidy. The colleges raise the rates. And so we need more subsidy. College costs are out of control. No, it's because you're subsidizing that. That's why they just keep raising their prices or passing on to someone else. It's the college model all over again.
If you insulate the consumer from the real cost of anything, what care do they have? I mean, they're only going to consume in terms of how it impacts them personally. So it's in fact, is a perfect segue into the other part of this bill, the ACA subsidy extension. When you read the media commentary around the alarmist description of the need to continue these subsidies that were part of the COVID relief package, and then you look into the numbers and say who actually who was drawn to Affordable Care Act plans that didn't have them before. And there were two groups. One was really low income and one was actually high income. The low income people qualified for subsidies before. So it was really more of a process of, hey, we lengthened open enrollment period. We educated more consistently and heavily and got people to sign up that could have signed up for Medicaid even before the Affordable Care Act and gotten free coverage. And then you look at these, or subsidized coverage. So when you look at the people that actually picked up coverage, we created a moral hazard where we drew people from employer plans, from individual plans that they previously had budgeted into their lives over to ACA plans with subsidy because their personal finances were benefited by doing so. A 60-year-old couple making $215,000 a year gets a subsidy. That's what we extended. So you have to scratch your head as a responsible American person and say, does that make sense? I mean, at least it should be worth a discussion,
right?
You know, but when you see the articles and they say, well, 3.1 million people could lose their health insurance, who's going to lose the subsidy?
Right?
Are the very poor? And are we telling the very poor you're off the health insurance? No, they were qualified even before the ACA. They'll continue to be qualified. Will forever continue to cover those folks. They just need to sign up.
Right.
It's that 60-year-old couple making $215,000 a year, which I think is worth a discussion. Do we really all need to chip in a few $100 billion more every couple of years so that we can subsidize a 60-year-old couple making $215,000 a year to get health insurance?
Right.
Maybe not.
Yeah. It's incredible. And this is, for years we've been talking about healthcare related stuff. Paul Seegert from PCS Healthcare Advisors. It's always the same conversation basically that we have, and it just keeps going and going and going. And the latest is this extension past an emergency, and anything that passes an emergency, you got to instantly have your guard up too, because it's a $740 billion tax the Senate Democrats got through, totally along party lines. There's climate health care package, and there's climate stuff in there. We'll get to that in a little bit too, because it really factors into where the money's coming from, and you're subsidizing one industry over the other. One other thing too I want to touch on before we get going is, and I think this one hit home for a lot of people, I think 1 out of every 3 or 1 out of every 4 Americans is diabetic, which is a sad indictment of our lifestyle here in the United States. But there's a proposal to place a $35 cap on commercial insulin, but it violated some wonky, parliamentary procedural rule or something. And so that's beyond me. And my eyes roll back in my head when I hear about budget reconciliation in parliamentary procedure. But they wanted to place a $35 cap on insulin, but that got scrubbed out by Republicans because it violated a procedural rule. What would that have done?
Well, it gets right back to what we were talking about in terms of if you insulate the consumer from the real cost, then you don't fix the real problem. You just push it forward to the next premium increase in our business. And that's what they were proposing with insulin, rather than solve the real problem, which is middle players attaching a significant amount of waste to the cost of insulin. 60% of what we pay for insulin is added on by these middle players who do not make insulin, who do not wholesale insulin or retail insulin. So you have $550, let's say, for a box of insulin pens, a box of Humalog pens. 330 of it is waste. And instead of saying, hey, that shouldn't be allowed, or we should have some common sense rules around how that works, is it really reasonable that the company that manages the formulary for your health plan and says, yes, a drug can go on the list, should get 60% of the transaction cost? I mean, that's extreme. And yet, instead of addressing that because of the power of lobbying and all the things that we tend to talk about a lot, instead, this bill was going to say, hey, go ahead and continue to rape and pillage the American economy and add 60% waste to the cost of insulin, but you can only charge the consumer in their healthcare plan design $35 in a copay. That's just permission to the industry to bump it from $550 to $700. Right. If the plan's paying and the consumer's insulated at $35 copays, that's just going to balloon the cost on the back end, but it won't be transparent and visible to the consumer. Then what happens? Yeah. It gets rolled into next year's renewal increase in premium, and that does affect the consumer. Right. When you find out yet again, I go to work in my open enrollment meeting, and they tell me, hey, you're getting a raise of $100 and your healthcare costs are going up $120. That's why. And yet we're back. This is allegedly somehow is going to cure inflation. I'm no economist, but that doesn't make a whole lot of sense to me.
Listen, I'm the worst guy you want doing your taxes or numbers because I look at that like a dog at a card trick and go, I don't know. But I that to me goes, well, it doesn't sound like it's really going to do anything to it may make inflation worse, actually, in that regard, because you think about it, if you're a private sector employee, some 2,200 million Americans are, 220 million Americans are, that what's going to happen is, you're going to get less health coverage, but your premiums are going to go through the roof, and that means less take-home pay. You're actually creating more inflation, aren't you?
At least in my area of expertise, I can see directly how this will increase the cost of healthcare, which certainly doesn't help people.
You're trying to save people money. I don't know. I mean, if you're on the government plan on Medicare, unfortunately, I think most of us will probably have to work till long after we're dead and able to continue to pay the burden for the transfer of wealth in this country. But nonetheless, Paul Seegert from PC Healthcare Advisors, thanks for laying this out so a dummy like me can understand it. I very much appreciate you.